Similarly, we have trend analysis. This utilizes all the fields available, makes a regression line, and sees the slope, whether it's significant or not. This uses the patient's individual data, and we'll talk about it in detail in the next talk. We also want to know the rate of progression because we want to determine how aggressive our treatment and follow-up should be. And best, as of now, is the standard achromatic perimetry, and we also must use the same program for each test. So how to get started? What you need is a good baseline. In fact, 2 fields at close interval and reliable fields. If you change the treatment or perform a surgery, you need to change the baseline, and all these are what you don't want, either in your baseline or in any of the other tests. Now we come to the 3 C's for progression. First is confirm, second is correlate, third is context. All these will help you diagnose progression with confidence. Always confirm a change. It has been seen in many studies that an abnormality detected on a reliable field on repetition just disappears. For example, in the oath study, about more than 80% on repetition turned normal, and in the CNGT study, there were false calls of progression in 57% patients. So we are not obsessive, but still repeat, and repeat to confirm a defect. Second is correlate. All these tests help you and not make a decision for you. You have to correlate clinically and rule out any overlaps with any other ocular disease causing a field defect or any outliers. And finally, the context. You have to look at the patient as a whole, look at the IOP control, the age, presence of pseudoexfoliation, and then take your call. So to achieve all this, how many do we need to do? Well, the guidelines say that you need to do at least 3 fields a year, that is 6 in 2 years, for 80%, with the 80% power to detect a fast rate of progression. And how many actually we are doing is pretty less. And finally, last but not the least, is the patient. Now, we usually use the grayscale to explain the field defect to our patient, and that time the patient looks at us and thinks, maybe it's the doctor's field, not mine. And this is because that's what the patient sees. He doesn't see the black spot we show him. He sees this. So it's very important to bridge this gap and motivate the patients to do the field. Tell him that it's the field and not the IOP control, which is the goal of the therapy. We want the patient to have a stable field. Thank you.